Well, hello, everyone. Thank you for joining us today. For those that don't know me, my name is Sue Verrilli, and I am the Education Coordinator here at the Northeastern Ontario Stroke Network. And I'm so glad you could join us today. I want to just take a minute and say thank you for your work. I know that you work hard and you persevere and you've been so committed through this pandemic. It seems like it's not ending, but I hope it is. And I just wanted to let you know that we appreciate the work that you do. Today, we're pleased to present this webinar. It's going to be about the newly released Canadian Stroke Best Practice Recommendations for Secondary Prevention. The webinar has been sponsored through an education grant from Pfizer, and we'd like to thank them for their support of stroke education. So as you heard, we're recording this webinar. We'll be posting it to our YouTube channel. And so we'll be able to use it as orientation for new nursing staff that are hired or for other healthcare professionals that might be interested in learning about these updates. Just so you know, and this is new information for you, but this is part one of a two-part education project. At the end of the presentation, we'll discuss part two and when we can book that and what the agenda will look like. So we'll hear about the updates today, and then we'll be able to have a part two where we'll have more discussion and production of how we're going to input these best practices. So I'll take a quick moment to introduce our speaker. Welcome, Colleen Murphy from Kingston, Ontario. Colleen's the Regional Stroke Best Practice Coordinator out of Southeastern Ontario Stroke Network. She did this presentation last year for her region. I think the best practices came out maybe around May or June last year. And so she's shared this. And so I think she's got a bit of knowledge around it and is going to be great for sharing the information, and going to ask people to please ask questions throughout. You can unmute and ask them. You can type them in the chat and I'll watch for them. But she's a wealth of knowledge. We have her for 1 hour. So let's see what we can get out of her. Just a little background on Colleen that I always like to talk about. Colleen was raised in Sudbury, and her and I went to high school together at Marymount College, graduated in the same class. So it was so great when we reconnected when I started with the Stroke Network. I'm like, I know a Colleen Murphy, and it turns out it was Colleen from Sudbury. So nice to make connections again. So thanks, Colleen, for taking the time today and to share your knowledge. And please take it away.
Oh, thanks, Sue. Can you hear me okay?
Yes, I can.
Oh, I have such fond memories of Sudbury and growing up, and I spent some time in Levac. Those were my first 10 years up north, and then the rest in Sudbury, and I do miss it so much. So I'm hoping to get up there soon and maybe have a visit with hopefully some of you. So I'm very pleased to be here and have this opportunity on behalf of the Stroke Network team of Southeastern Ontario to present on the updates to the secondary stroke best practices with you.
Am I muted or no?
That's okay. Just so I think she's on mute now. So this, as Sue said, this is meant to be an informal presentation. So I'm going to pause a bit after each slide. So please feel free to ask any questions or provide comments throughout. So you guys are the clinical experts, and we are here to learn together. So the source and content from this presentation are from the recently updated Canadian Stroke Best Practices for Secondary Prevention of Stroke. So you're going to see some links on the slides. So if you are interested and want to look further, they're there for you. And I'm going to also share the PowerPoint. So there'll be some notes underneath each slide. And the notes are basically the Canadian Stroke, all the recommendations. Okay, so this is one of my favorite things to talk about, or one of my favorite slides. So I think you guys know this. So our go-to resource to learn about stroke best practices, obviously, is the Canadian Stroke Best Practices from Heart and Stroke. So at the top here, you'll see a link to the Canadian Stroke Best Practices, which is on the Heart and Stroke website. I would imagine and hope that you're all familiar with this site. So you can just simply Google stroke best practices and it will come up for you. So under recommendations, you'll see various chapters, including the secondary prevention of stroke. So after clicking on the chapter, there's a link to a published article which provides a summary, okay? There's also a module. that contains more content. And under each section of the recommendations, there are a few additional items, including knowledge transfer tools and the summary of the evidence. So if you want to get quickly up to speed with the latest evidence, I would suggest that you look at those summaries. So what I found with this updated version, and I'm probably some of you have already have looked at it, but I find it's easier to see the changes. Okay, so they're highlighted in red throughout. And in the article, which I like to refer to because I think it's about 20 pages, it's bolded. So you can definitely see the changes. So for this presentation, I'm just going to try and review a smattering of the changes to pique your interest that I have noticed in the short time that we have today together. Okay, so, but first, I just want to mention that we all face challenges with implementing stroke best practices. And what helps us is to embed those best practices into our usual processes, such as our orientation, our protocols, care pathways, our EMRs, and our checklists. So what is most helpful for implementing stroke best practices? Well, it's you guys. You are the knowledgeable team. We learn from you. You are the most important resource. So everyone plays a critical role in relation to secondary stroke prevention, from presentation right through to the community. So prevention applies across the full continuum of care. Okay, so let's touch on risk stratification, investigations, evaluation, and virtual care. So first off, triage. So I noticed the biggest change really in relation to triage with this latest update. So the recommendation for risk stratification or triage under the prevention chapter, I have to say, do not refer to patients meeting the acute stroke protocol or code stroke, who may be a candidate for thrombolysis, which is TPA, and or endovascular thrombectomy or EVT. So the main change to the triage recommendations is that they have been simplified greatly. So let's say you have someone who presents to your setting with new symptoms of stroke. Perhaps the symptoms resolved a day or two ago. So now all patients with any type of new stroke symptoms, whether they are transient or persistent and occurring within 48 hours, they are to be sent immediately to the eMERGE with capacity for stroke care, including on-site brain imaging. So those appearing with a TIA or minor stroke at greatest risk for recurring stroke during this 48-hour time period. So that's why they've made this sort of change. So for all others with stroke symptoms onset greater than 48 hours, a comprehensive stroke evaluation and investigations should be done as soon as possible. So with this update, remember all those risk categories? You know, we had very high, higher, moderate, increased risk, lower risk, and all those different timelines and all the different specific stroke symptoms and signs have been removed. So the triage recommendations are from the lens, I feel, from the referral source. And but a provincial group is working on updating the 2015 Ontario Stroke Network triage algorithm, which is more from the lens of the stroke prevention clinic. So, you know, you get all those different referrals that are coming in from all those different sources, right? So it's hard to triage. So we have to have a system. So we are working on that, and we're working closely. And Deanne was part of that work, who's on this call today. So just a little bit more about triage. So under clinical considerations, so I just have to mention, I think you guys know this, the recommendations throughout refer to, you know, have assigned levels of evidence, whether it be A, B, or C. But the clinical considerations, and you'll see them more, I find, more and more, they are your reasonable practical advice provided by consensus of the group that wrote the best practices on specific clinical issues that are common or perhaps maybe controversial and lack the research to guide practice. So for this slide, for the triage clinical considerations, what is new is to also refer to the stroke expert if you suspect uncommon cause of stroke, including young stroke, perhaps a family history of young stroke, suspected cerebral vasculitis or other intracranial vasculopathy, or suspected hereditary or acquired thrombophilia. Symptoms of vertebrovascular ischemia can influence and can fluctuate over longer time and be mistaken for stroke mimics. However, they require urgent assessment, neurovascular imaging, and management. Vertebrovascular symptoms are often missed in our region, we find, and just so you guys already know this, they rarely occur in isolation. So with this last bullet here, in some regions, in some centers, urgent rapid TIA clinics are available that have rapid access to diagnostic services, and they may be considered as appropriate referral options for TIA minor stroke patients where available and accessible. We don't have this in the Southeast. Patients are directed to the emergency department within that 48-hour time period first, if needed rapid assessment. So I think I'll just stop. Is there any questions with regards to triage? So what we will do, like we're working on this algorithm, Deanne's quite familiar with it. I probably will send it out to Sue for your feedback, and it would be wonderful if we can get your feedback on that triage algorithm. Okay, I'll continue.
It sounds good to me, Colleen. Just send it to me and I can forward to people.
Okay, that's great. And remember, it's draft, but feedback is certainly very welcomed.
And how quickly do you think that will come?
Well, I can send it to you next week.
Oh, okay, perfect.
Okay.
No rush.
All right, no
Thank
worries. You. Okay, or even today if I get it together. So while in the emergency department, we know that we complete a plain CT or MRI and concurrent vascular imaging, with CT angiography or CTAs being sort of what is preferred now. If unable to do a CTA, then we do carotid ultrasound or Doppler. So if the patient's symptoms resolve and you're still suspecting a TIA, you still complete this imaging as soon as possible and prior to discharge from the emergency department. So this has changed from within 24 hours for imaging to be done now as soon as possible before discharge from the emergency department. So in the previous guideline, it was indicated that the imaging was completed based on the different time frames, based on the different triage categories. So it is emphasized in this guideline too that CTA is first-line vascular imaging. However, carotid ultrasound or Doppler and MRI are reasonable alternatives if CTA is not possible. So it used to say acceptable alternatives, and now it's saying reasonable alternatives. So in Kingston, CTA is done at the time of the CT, at the time of the CT, and in community hospitals, often a Doppler is ordered and is mostly done as an outpatient. However, we are getting more access to most places to CTA, but the availability tends to be during the weekday times only. So there's new clinical considerations for MRI. So brain MRI is superior, as we know, to head CT scan in terms of diagnostic sensitivity for identifying those small ischemic lesions or infarcts in patients presenting clinically with TIA or minor stroke. So decisions regarding MRI should be based on access to MRI availability and timing of the appointments. For maximal yield, MRI should be done as soon as possible after the TIA and ideally within 7 days. So MRI is particularly useful in those lower risk patients with transient symptoms in whom the presence of ischemia would change your management. So common scenarios here where for urgent MRI, where it can be valuable include, say you have a normal CT of the head despite symptoms persisting greater than 24 hours. If you suspect a brainstem or cerebellar ischemia, as we know, CT head is insensitive for detecting strokes in the posterior fossa due to bone artifact. And if there's focal transient symptoms that are clinically atypical for brain ischemia. So that's it for the imaging. I'll just pause for any questions.
Nothing yet. People can type in
Okay.
the chat
Yeah,
if
and
they
you can
want.
just interrupt me, so it's
Mhm.
fine. So I do, I always, these tables that get getting updated, the blood work tables, I do refer to them often and I print them off so I have it handy with each new update. So I compared this latest update table of the blood work to when the acute stroke best practices were updated in 2018, which updated the blood work table from the 2017 prevention guidelines. So that was the previous guideline was in 2017 for prevention. So what's new? Well, the initial and the follow-up blood work are now all combined under one section. So I think the timing is up to our local stroke protocols as was previously indicated. So they've added here now more liver enzymes. Before it was just ALT. And I looked back, I remember there was liver enzymes way back and it actually was there in the 2013 guidelines. So it's come around again. Troponin has now been moved down to optional. And here in Kingston, we do a troponin actually across the whole Southeast, first when a patient first comes in who are presenting on an acute stroke protocol. So under optional labs here, they added in if giant cell arteritis is suspected, so that would be retinal ischemia or headache. They've suggested doing ESR or CRP, which is C-reactive protein, as you know. There's also a thrombophilia screen. It used to say coagulopathy screen. They've added in vitamin B12. They've also added in this whole section of venous thrombosis testing. So that's, your protein S, protein C, and so forth, which was also present back in the 2013 prevention guidelines. And there's a recommendation down here, you might not be able to see it, and sorry about the blurriness, to limit extensive thrombophilia testing for hereditary hypercoagulable disorders to select situations. For example, unexplained cerebral venous thrombosis or PFO. So if you suspect hypercoagulable state, consider consulting, of course, hematology or a thrombosis expert. So for cardiac studies for detection of AFib, the recommendations look the same when I looked at them for screening for atrial fibrillation. It was noticed to use a tiered approach to searching for AFib, and that's what we do. So, we start with an ECG and then we move on from there. If there's no atrial fibrillation on the ECG, then there's the 24-hour or more for ECG monitoring. It used to just recommend at least 24 hours, and then or at least 2-week monitoring if your initial heart monitoring doesn't detect the AFib. So what's new, and I don't know why this seems sort of simple to me, but what's new is if people are over 65 with ischemic stroke or TIA, you palpate the pulse, auscultate the heart sounds, or do an ECG rhythm strip to screen for undiagnosed AFib. So I think we already do that, but it's here in the recommendations. So for echocardiography or there's a bit more emphasis now that routine echo is not needed for all stroke patients, but is to be considered for ischemic stroke or TIA with embolic etiology or undetermined source. So you're suspecting cardioembolic etiology. So for here, this last bullet, for those under 60 years of age who are being investigated for an embolic ischemic stroke or TIA of undetermined source, echo with saline bubble study, and I'm sure you've heard of the bubble studies, is recommended for detection of a possible PFO if it may change patient management. For example, if your patient is a candidate for PFO closure, or if anticoagulant, if you're deciding on anticoagulant therapy, if PFO is detected. Okay, so this is a brand new section. It's on virtual care, which I think is not new for some, but maybe now being used more during these COVID periods or these COVID peaks. So in Kingston, we've used a hybrid or combo approach. And we've mostly, in this latest, in a couple of the peaks there, we mostly converted to virtual with either video using OTN via the computer, so the physician's computer linking to the patient's home computer, or they would revert to telephone. And if needed, they would bring the patient into clinic and have an in-person visit. So for these recommendations, as you can see here for secondary stroke prevention services, should establish processes and technology to increase and ensure access to services through virtual care delivery mechanisms for patients who do not require in-person visits, and especially patients living in rural and remote settings. So in our area, it's very rural, and in your area, of course, it's very rural, and in some areas, there's some remote settings. So clinicians should follow established, validated criteria to determine the best mode for each patient at each encounter based on the purpose and goals for each visit, taking into account patient preferences and values. So we have here, I've added a link here to the Canadian Stroke Best Practice Recommendations Virtual Care Toolkit for additional information and guidance. In the toolkit, there is a section on prevention. There are tips for clinicians and for patients to make the visit more effective, to help the patient feel more prepared, in other words. So what is helpful, we found from our experience, and there are some benefits, but I think one of the most positive benefits, obviously, is for the patient living in these rural areas to have better access, but also to link in family members to participate in their appointment, which I think is really, really nice to have. So here's a long list under clinical considerations. I'm not going to go through this. I'm just going to touch on a couple, the first couple. So consulting sites and individual clinicians should have triage protocols and local intake criteria in place to ensure patients referred to their services are seen in a timely manner, especially high-risk patients. So the use of virtual care for stroke prevention should include decision tools to identify patients who require in-person visits and those who can reasonably be managed through virtual care, and a scheduling system for virtual visits that support a collaborative team approach to care where appropriate and feasible. So I think that is the part that we tend to struggle with, is having, so we've sort of lost that interprofessional team approach with the virtual visits. So we have to make some improvements with that, obviously. So there's many other clinical considerations listed here, but making use of these home blood pressure monitors is recommended to use that option more. And I know one of the nurses, it's at the Brockville Stroke Prevention Clinic here, is interested in incorporating home blood pressure more into their visits there. And there are some nice resources about this on Hypertension Canada's website, which you're probably familiar with. And also for detecting atrial fibrillation, consider using some services that send prolonged cardiac monitors to patients' homes, and then this is returned to the service by mail.
Colleen,
Yes.
can I ask, and maybe everybody else knows this but me, but what do you mean by a scheduling mechanism for virtual visits? What would be an example of that?
Maybe I'll let the other group talk first about that.
People have a scheduling mechanism, or anyone?
I know in our system, we have in our electronic system, we have to make sure that we deviate between virtual, telephone, or in-person visits in terms of that system. And then basically have a mechanism to be able to schedule patients, you know what I mean? Like have that whole process developed for that. I think that's what that means, Sue. That's what it means for us here.
So it's kind of like the online system you use for scheduling.
Yeah, and then there's some groups, we don't have that ability, but I know in Brockville, for the in-person, let's say, but this is more than just virtual. It extends to all visits. They can actually have automatic referrals to their clinic through their electronic systems for in-person, for the visit itself, and then the clinic themselves decide whether it's virtual or by in-person.
Okay.
And I know some of the primary care EMRs are well equipped now with their platforms to send out email reminders about their visits and things like that. But I'm digressing from the virtual component of this. But provincially, there is work being done on this. They're updating that memo 5 regarding the stroke prevention clinic contingency planning on the Ontario Health Ontario's website. And this is being updated, like I said, by this provincial group, and they're going to include a decision-making guide for in-person versus virtual, and that might help. We're hoping to get that out soon. We're almost at hopefully the end of the COVID waves, but it'd be nice to have this out to help for future. Okay, let's move away from virtual, if that's okay, to some fun stuff. So this is most of the content on this next section you already know, and it's just a reminder of those basic elements that we cover off during each of our visits in the clinic. So just they have made some references to some studies here. So the systematic analysis of stroke and risk factors from the Global Burden of Disease study that covered almost 200 countries, including Canada, showed that 90% of the stroke burden is connected to modifiable risk factors. Air pollution, which I thought was interesting, has emerged as a significant contributor to stroke burden, especially in low and middle income countries. The risk factor that increased the most out of all the countries was a diet high in sugar sweetened beverages. And this was even greatest noted in high income countries. So similar results in the interstroke study of over 20 countries, including Canada, where 90% of strokes are attributed to 10 risk factors. So the self-reported history of hypertension was the greatest risk factor for stroke. And from those 10 risk factors, the 5 that accounted for more than 80% are hypertension, current smoking, abdominal obesity, diet, and physical activity. So in terms of healthy, balanced diet, I didn't notice a lot of changes here, but we counsel and educate patients with TIA or stroke to follow a healthy eating pattern and balanced diet, or refer to a dietitian. So referring to a dietitian used to be under weight management, so it's been moved now to this section. And what's new here is the term healthy eating pattern. And referring to healthy eating pattern is also under clinical considerations to counsel and educate our patients regarding healthy eating patterns that focus on whole, natural, minimally processed foods instead of specific nutrients such as cholesterol. And referring to Canada's food guide is back in. So the guide contains a lot of visuals and links to suggestions, for example, healthy food options, such as choosing foods that are fresh or minimally processed, and choosing healthy fats, eating a variety of healthy foods every day, being mindful of our eating habits, enjoying your food, and cooking more often. So still recommended is to follow the Mediterranean type diet, and they've added now the option of the DASH diet. So high adherence to DASH or the Mediterranean diet has been associated with reduced risk of stroke. The Mediterranean diet is a way of eating that's based on the traditional foods of countries that border the Mediterranean Sea. The foundation of the diet are plant-based foods such as whole grains, vegetables, legumes, fruits, nuts, seeds, herbs, and spices. So olive oil is the main source of added fat. So DASH is similar and includes other information about lowering our sodium and increasing dietary potassium. So I always refer to or remember what the dietitian here attached to the Kingston Stroke Prevention Clinic says, that any one of these diets is good, really. There's some new counseling suggestions here for food, including there's more about consuming minimally processed foods and to consume lower fat, sugar, dairy products, unsweetened fortified soy beverages. Pick high fiber choices such as whole grains, beans, and legumes instead of processed or refined grains, such as white bread or pasta, and have water as your drink of choice for hydration. New but not listed here, in addition to the sodium recommendations, are under the clinical considerations, is that achieving a sodium of less than 2 grams or 2,000 milligrams may be very difficult. So encourage a gradual decrease in foods that are high in sodium, which will allow your taste buds to adapt. And I've noticed this myself, I find. Okay. So physical activity. So interstroke study indicated that physical activity was associated with reduced risk of stroke, and the global burden of stroke study indicated that lack of physical activity was more attributable to stroke in high income countries. So this heading used to say exercise, it's been changed to physical activity. We are to counsel and educate to reduce sedentary behaviors, and they've added in here what's new is sedentary time, and work towards increased activity goals as tolerated. Participate in aerobic exercise most days of the week to accumulate at least 150 minutes per week in episodes of 10 minutes or more, in addition to routine activities of daily living. So they changed the wording from dynamic exercise of moderate intensity to aerobic exercise. And what else is new is to consider the initiation of aerobic training post-stroke or TI once the patient is medically stable. So to ensure continuity of appropriate interventions, reassess at transition points along the continuum of care based on the changing neuromotor and cardiopulmonary capacities to participate in aerobic training. And a clinical consideration here is that aerobic exercise intensity should be individualized as per these factors here that you can just read. And we've added a link here to the Stroke Engine's aerobic exercise, which contains clinician, patient, family information and guides, which are good to have, and a link to the aerobics 2019 update best practice recommendations. So for weight management, the global burden of stroke study indicated that there's an increased risk of stroke associated with being overweight or obese. In Canada, the estimated risk was higher at 28.4% compared to the global burden at 23.5%. So the interstroke study indicated that increased waist to hip ratio was associated with our increased risk of total stroke. And this is, I'm sure this information is very familiar to you. So just to introduce this section, so we counsel and educate individuals with TI or stroke who are overweight to set healthy weight loss goals and to develop individualized plans to achieve those goals. And what's new is this recommendation here is to use more than one approach, and I'm sure we all do, to support sustainable weight loss or weight gain. That includes counseling and education, increased physical activity, and behavioral interventions. And they've added this clinical consideration is to explore the root causes of weight gain and avoid stigma and judgment. And there's a link here to the latest Canadian Adult Obesity Clinical Practice Guidelines. So I'm whipping right through here. So I didn't see any changes to the alcohol consumption recommendations, but regarding recreational drug use, I'm just going to repeat some of the previous information that individuals with stroke and known recreational drug use that may increase the risk of stroke, such as cocaine and methamphetamine, which unfortunately is a high incidence in our community around here, should be counseled to discontinue use and should be provided with appropriate support and referrals to services and resources for drug addiction. One study indicated that cocaine use within 24 hours was associated with a significantly increased risk of ischemic stroke, and most common route was smoking cocaine or crack cocaine. So use of coke and methamphetamines and association with increased risk of stroke is well established in the literature. And what's new here is they are now including cannabis. So cannabis use has conflicting results in relation to the association with stroke risk. A new recommendation up here is that if taking cannabis for medical indications, counsel regarding any potential increased risk of stroke to support informed decision-making regarding the use of cannabis. Very general recommendation. But under clinical consideration at present, there is some possible association of smoking cannabis with increased stroke and cardiovascular events. However, there's still lack of high quality evidence to provide clear guidance, and we need to consider individual patient factors. So there's a link here to Canada's lower risk cannabis use guidelines, which has some helpful guidance for people who want to, who wish to continue to use cannabis. So one tip is to counsel about buying cannabis product that have lower THC and higher CBD. So smoking cessation, I didn't see a lot of change here, and the stuff here at the top is what was in the previous recommendation, but there's a high level, and I just want to repeat that there's a high level of evidence that in all healthcare settings along the stroke continuum, patients' smoking status should be identified, assessed, and documented. Pharmacotherapy and behavioral therapy should be considered in all smoking cessation programs and interventions. High-level evidence supporting 3 pharmacological agents to be considered as first line are still nicotine replacement therapy, varenicline, and bupropion. So there is a link to a table, which I always refer to, providing a summary of the properties of these agents on the Canadian Stroke Best Practices site. So new stuff here. So begin pharmacotherapy for smoking cessation as soon as possible while in hospital. So this had been removed, but it had been there previously, so it's back in again. So, and it's also valid to use a stepwise reduction approach that starts with cutting back and progresses to full cessation. And consider linking to virtual smoking cessation supports and clinics to optimize your success and the patient success of cessation. So with us, we do have some smoking cessation maps on our website that were designed by Public Health for primary care, but can be used by others. And on the Core Health website, there is housed a sample smoking cessation medical directive, if you'd like, and also a quality improvement plan that may be helpful. This is new though, vaping. So clinical considerations for e-cigarettes is new. So e-cigarettes, we know, are commonly used in attempts to stop smoking. So while some people may find vape products helpful in smoking cessation, the evidence around their population-based effectiveness is not clear. So there is some evidence that shows people who use vaping as a way to quit cigarettes may continue to still vape. So there's emerging evidence about an association between vaping and elevated blood pressure. However, the strength of that association is not clear at this time. So the most common pattern in Canada is to use both vape and combustible tobacco products. So our education and counseling strategies should cover both. And education and counseling should include the risk and benefits, including those of the younger age groups who have had a stroke or TIA. So with oral contraceptives and hormone replacement therapy, they've added more recommendations and ones now for pregnancy, which is a topic really for its own webinar. Just a lot to talk about. There's also a whole chapter of prevention of recurrent stroke in pregnancy. And some of the recommendations have crossed over into the prevention section. So I'm just going to cover off just a bit on contraception and HRT. So there was a Cochrane review that indicated that combined oral contraceptive users were at increased risk of ischemic stroke compared with non-users. So alternatives including progesterone-only oral contraceptives, progesterone-only or non-hormonal IUD devices, or barrier contraception can be considered in consult with experienced providers in contraceptive methods. So for HRT in postmenopausal women, a Cochrane review indicated that for either primary or secondary prevention of cardiovascular disease, had little, if any, benefit and causes an increased risk of stroke and VTE. So in the Women's Health Initiative trial, the HRT using combined estrogen and progestin was associated with an increased risk of ischemic stroke in healthy postmenopausal women. So getting back to what's new. So what's new for 2020, contraceptive management alternatives to estrogen-containing hormonal contraceptives should be considered for women with a history of migraine with OR, especially if they are also current tobacco smokers. And I think most of us are familiar with that recommendation. So it also mentions hypertensive disorders of pregnancy here. So it discusses the use and dose of aspirin to reduce the risk of a hypertensive disorder of pregnancy. So this discussion should be individualized based upon the women's risk of this disorder, whether they've had a prior ischemic stroke, for example. So this is something new I was not familiar with, in vitro fertilization. So for women who have had a stroke or TIA and are considering in vitro fertilization, we are to provide counseling and education about the risk of fertility therapy, including the potential risk of hyperstimulation, and monitor for complications, assuming all other stroke in the young and management plans are followed and optimized. So that's a new one.
Colleen, it's about 20 minutes left, just so you know.
Oh my goodness. Are there any questions? I'm just going to keep going.
No, I'll
Okay.
let you know if a question comes up.
Okay. So this is kind of neat. This emerging risk factors here for, and the first one here is influenza. So seasonal influenza has been shown to be associated with increased risk of stroke and heart disease. The flu-like illnesses are associated with an increase in short-term risk of stroke, particularly in those under the age of 45. And one study indicated that there is a small patterns of stroke occurrence that may be explained by variations in influenza activity. So what's going on here? So there may be inflammatory mediators causing a prothrombotic state. So there may be increased odds may also be due to the general effects of the flu, such as fever and dehydration. So in terms of the vaccination effect, having the vaccine can reduce the added risk of stroke. And a Cochrane review indicated that studies in persons with cardiovascular disease may reduce death and may reduce combined cardiovascular events such as MIs and stroke. However, we need more studies. So for this recommendation, it's recommending that the influenza vaccination is recommended, and particularly in people with cardiovascular risk factors. The other emerging risk factor here is air pollution and stroke risk, which I'm not an expert on, but emerging evidence that long-term air pollution exposure is an important vascular risk factor, and concerns about chronic effects of long-term exposure, especially the effects of fine particulate matter on cardiovascular and respiratory health. So particulate matter is a term used for a mixture of solid particles and liquid droplets found in the air. So the size is directly linked to the health, and fine particles can reach deep into the lungs and may reach the systemic circulation. So these particles can be made up of hundreds of different types of chemicals. So the recommendation for us is to counsel our patients regarding long-term exposure to air pollutants, particularly avoiding or minimizing exposure to particulate matter of less than or equal to 2.5 micrometers in diameter, which may be associated with an increased risk of stroke and cardiovascular disease. So I'm learning more about this, and we have a speaker coming up at our February primary care stroke prevention clinic event. So I'm hoping to hear more about this. And here we have a link to a cool resource. It's a 3-page fillable stroke prevention sort of discharge summary resource that you can have, and maybe you already use this, which also contains the signs of stroke. And if you're interested, I can send you the Word version that you can tailor to your own setting. So it starts in the stroke prevention clinic, and it can be carried through to primary care, and it may be helpful for those coming in, those community and rehab home care providers coming into the patient's home. Okay, so I'm going to move on to hypertension, diabetes, and dyslipidemia. So I didn't really see any changes related to assessment of blood pressure, but under blood pressure management, our target's still the same. So target blood pressure of less than 140 or 90 for ischemic stroke or TIA, and a target systolic blood pressure of less than 130 for your small subcortical strokes such as lacunar stroke. So for what's new in these recommendations is that with intracerebral hemorrhage and stroke and secondary stroke prevention, we aggressively monitor, treat, and control blood pressure to less than 130/80. What also is new is to strongly consider initiation of antihypertensive therapy after acute phase of stroke or TIA. There's just a bit more stronger language in the recommendations. And they've now introduced here with a new recommendation to treat with ACE inhibitor plus a thiazide or thiazide-like diuretic. A long-acting diuretic may be considered over a short-acting one. And we know that the use of ACE and an ARB together is not recommended. So in the previous guideline, it only mentioned to start on hypertension therapy without mentioning the class of medications. So here under a new clinical consideration is that patients with non-revascularized critical intra or extracranial arterial stenosis experiencing neurological symptoms attributed to hemodynamic cerebral or retinal ischemia, so you might have low blood flow or hyperperfusion, it's reasonable to aim for a slightly higher than usual blood pressure target for prevention of hemodynamic stroke. And we've seen this in the emergency department. Patients present with a TIA and end up with a stroke, big stroke. So if asymptomatic though, follow your usual blood pressure targets in post-acute stroke. And here's the link here to the Hypertension in Canada guidelines, which are aligned well with the Canadian Stroke Best Practice recommendations. So for lipid management, lipid assessment, I didn't see anything new regarding lipid assessment or screening, but there were some changes with regards to lipid management. So there's been new research now supporting more aggressive lipid targets of less than 1.8 millimoles per liter for LDL, which has been lowered from previous lower than 2 or 50% of LDL reduction. So the lower target previously was just for patients with stroke and acute coronary syndrome or coronary artery disease in the previous guideline. And here now there's listed some add-on therapies to consider for people that are struggling with their target and well on statins. So individuals with ischemic stroke and cardiovascular disease with an LDL persisting greater than 1.8 despite statins, you can consider ezetimibe for this. So if you have cardiovascular disease where you're still not reaching target, you consider obviously referring to maybe a lipid expert or one of your stroke experts in your clinic to consider adding a PCSK9 inhibitor to lower your LDL cholesterol. So I think we know what that does. Our liver cells have receptors that sweep away excess cholesterol, and the PCSK9 destroys them. So that's where the inhibitors come into place. So they latch on to those PCSK9 proteins and block them from acting, so more receptors are able to do their job. So right now there are 2 approved medications, so alirocumab or Praluent and evolocumab. I hope I'm getting this right, Repatha. So they are expensive though. So in terms of high triglyceride levels, so there's some add-on therapy recommended here. So if you have this, if you have added cardiovascular disease or diabetes and additional vascular risk factors, and you continue to have higher triglyceride levels despite the statin, you can consider icosapent ethyl. The brand name is Vascepa, and you may be this may be considered to reduce the risk of vascular events. So for statin intolerance, to include, that includes your persistent myalgias or your persistent significant liver enzyme abnormalities, the indication for statin therapy should be confirmed and take a closer look at how those statins are contributing to those patient symptoms, including temporary statin cessation with observation of symptoms, dose readjustment, or use of alternate medications. And refer to the Canadian Cardiovascular Society dyslipidemia guidelines. And there's a link here to that. I didn't see any changes with diabetes screening and assessment. For diabetes management, the target appears to be the same, including A1C target of less than or equal to 7% for patients with diabetes and stroke or TIA. What's new is the addition of agents that can be added to standard regimens to improve glycemic control in patients with type 2 diabetes who have trouble achieving their blood glucose targets. So studies of these newer anti-hyperglycemic agents include the SGLT2 inhibitors and the GLP-1 receptor agonists. They show great improvement for stroke outcomes. So they are recommending the addition of these medications. And then there's this clinical consideration down here is, so while there is a benefit of pioglitazone for stroke prevention in patients with positive insulin resistance, there's also an increased risk of fractures and bladder cancer. However, what's new here is what's in red. So a post hoc analysis of patients in the pioglitazone trial with prediabetes and good drug tolerance suggested a benefit of pioglitazone over placebo with regards to stroke and other cardiovascular outcomes. But the decision to use this medication should be considered based on, risk benefits and looking at the individual patient.
So Colleen, we have
Yes.
10 minutes left. So I'm going to suggest that we go over time so we can get it all recorded. And if people have to leave, they can catch the rest on the archive video, if that's okay with you.
Okay. And please feel free to just interrupt if you have any questions. I'm kind of just whizzing through this. There were so many changes. It's hard to cover it.
Yeah, it's good.
Okay. So what's new here for antiplatelet therapy? They've included the acute antiplatelet therapy emergency department recommendations under which you find under the acute section. Now it's under the prevention module. So I'm just going to talk about what's applicable maybe for your particular setting. So for TIA or minor ischemic strokes who are being discharged from the emergency department, antiplatelet therapy should be started prior to discharge. And I know that's happening in most places. So all those patients with acute ischemic stroke or TI not already on an antiplatelet should be treated with at least the loading dose of 160 milligrams of aspirin immediately after your brain CT image has excluded a hemorrhage. So in relation to antiplatelet therapy, though, for secondary prevention, stroke prevention, antiplatelet therapy should be started within 24 hours of symptom onset, ideally within 12 hours before discharge from the emergency department. So if they're going to the emergency department. So who gets dual antiplatelet therapy or DAPT? Well, minor stroke TIA of non-cardioembolic origin. So those are the folks, and anyone with symptoms of minor stroke or TIA, and they don't have a major risk for bleeding. So what you give is a single dose of clopidogrel or Plavix, so that's 300 milligrams or 600 milligrams, plus ASA 160 milligrams, followed by your 81 milligrams of aspirin and your clopidogrel of 75 milligrams for 21 days, then followed by single dose or monotherapy after. So there's longer duration of DAPT beyond 21 days is not recommended unless there's specific indications. Say they have a coronary artery stent or they have intracranial atherosclerosis. Another reasonable short-term dual antiplatelet treatment, which we're seeing now, is low-dose aspirin plus ticagrelor, and that is to be given over 30 days. So there is a higher bleeding risk, though, with this combination. So maximum benefit was observed in patients with ipsilateral large vessel atherosclerotic disease. And under clinical consideration in relation to use of ticagrelor, a sample can be taken from the patient to do pharmacogenic testing to identify patients with clopidogrel resistance. However, its clinical implications for stroke prevention treatment are unclear at this time. Now, I know in our area, I don't believe we're doing this, and I'd be interested to know if you folks are doing this to see if someone may be resistant to their Plavix or their clopidogrel. So what's new for patients with embolic stroke of undetermined source or ESUS and no known AFib? Oral anticoagulant is not currently recommended over low-dose aspirin. However, also new under clinical consideration is to follow is for carefully select patients with coronary artery disease or peripheral artery disease, meeting the COMPASS trial criteria, and they have low bleeding risk and no history of lacunar stroke or hemorrhagic stroke. You can consider rivaroxaban 2.5 milligrams twice a day, and low dose aspirin is reasonable. However, this should be used this should be started not within the first month after stroke. There's also an Arcadia trial starting, it's underway, looking at apixaban and aspirin in a subset of the ESUS patients who have atrial myopathy, and we're partaking in that research study. So for non-valvular AFib, this refers to AFib in the absence of moderate to severe mitral stenosis or mechanical heart valve. So we know that patients with ischemic stroke or TIA and AFib should receive oral anticoagulant therapy for secondary stroke prevention. What's new is that for patients with ischemic stroke or TIA and AFib, oral anticoagulant is strongly recommended and is recommended over aspirin or dual antiplatelet therapy. And I believe we already know that. And then for most patients requiring anticoagulants for AFib, a DOAC or a direct oral anticoagulant is recommended, such as, apixaban, dabigatran, edoxaban, or rivaroxaban, and it should be prescribed, I said, over warfarin. So there are some revisions to the timing of initiation of oral anticoagulant therapy, which is found under clinical considerations. And mostly what's applicable to you folks is if they have like a brief TIA, or there's no visible infarct, you can start anticoagulation within the first 24 hours. And if it's a minor stroke or a small infarct on imaging, 3 days post-stroke. And then the rest are for more the moderate and the severe stroke. So what else is new? Well, for patients with AFib who experience ischemic stroke or TIA in spite of already being on anticoagulation, it is recommended to identify and address medication non-adherence, ensure the correct dosing of the DOAC or warfarin INR target, avoid DOAC's drug-to-drug interactions, investigate for and treat other potential etiologies for the stroke, and promote general vascular risk factor modification. So new, what's added here under clinical considerations, either continue the current oral anticoagulant or switch to a different anticoagulant are reasonable options. However, the evidence is lacking to make more specific recommendations. So adding aspirin to oral anticoagulation, though, is not recommended. So I have to repeat, medication adherence should be continuously assessed and reinforced for patients on all oral anticoagulants at each follow-up and each stroke prevention clinic visit. So what's new in terms of here is patient, in terms of the adherence, is patient and family members should be provided education resources and ongoing monitoring regarding AFib and adherence to enhance the compliance and address those potential barriers in a timely way. What's new also is for patients prescribed DOACs, avoid inappropriate underdosing as it is associated with increased risk of stroke. And what also is new is for those folks that have coronary artery disease and say if they're 1 year post their PCI or their CABG, the addition of an antiplatelet to a DOAC is not recommended then. And I've got a link here to the CCS guidelines and the thrombosis guidelines. And I always like this Appendix 4. Take a look at that. You probably already have. It's for the selection of the anticoagulant agents for the management of AFib after stroke or TIA. Now, I'm not going to go through the next set of slides. I'm just going to say what's new here is that there are perioperative recommendations if on oral anticoagulant medication or antiplatelets. So it's kind of neat. It is based on Thrombosis Canada, and there's a nice little table to tell you what's low risk, bleeding risk, moderate risk, high risk, and what to do for this. And I really think this might not be too applicable to you folks, but you may be having a patient on your list who needs carotid endarterectomy. And say, for instance, maybe this last one, if they are on dual antiplatelet therapy, you're to continue this medication if the carotid endarterectomy is scheduled within 7 days. Okay, let's talk about carotid stenosis. And there were a fair bit of changes, but maybe I'll just briefly say under imaging. So if revascularization for the patient is being considered for carotid stenosis based only on, say, if you only have a carotid Doppler ultrasound, then you have to really have a CTA or MRI to confirm the degree of stenosis, as well as to assess for those that tandem disease, such as involving ipsilateral intracranial arteries. Also, carotid Doppler may still be needed, as there may be lots of calcification on the CTA, and you need to have the Doppler or the carotid ultrasound to further assess. So patients with symptomatic event attributed to ipsilateral 50 to 99% carotid artery stenosis should be evaluated without delay for potential carotid revascularization. And that's not new. But for us, what's new is here they've divided up into men and women. So for in men with 50 to 99% and women with 70 to 99% symptomatic carotid artery stenosis, carotid endarterectomy is recommended and should be performed as soon as possible, ideally within 14 days, and that has not changed. In women with 50 to 69% symptomatic stenosis, carotid endarterectomy may be considered in those at highest risk of stroke recurrence and upon consideration of other patient factors. So the evidence, unfortunately, at this time shows the greatest benefits for men. So in men with 50 to 69% stenosis, the greatest benefit is done within the 14 days, and that effect diminishes beyond 14 days. And here's a clinical consideration. So for those patients, it may, who have stroke, it may be reasonable to lay, carotid endarterectomy beyond 48 hours. And for patients with moderate or severe stroke due to symptomatic carotid stenosis, the benefit of carotid revascularization is uncertain. And here we're doing more, if they go in to do EVT, they tend to do, and they see carotid stenosis, they do tend to do carotid artery stenosis, carotid artery stenting at the same time. But if they don't do it, then they should be considered for subsequent stenting or carotid endarterectomy if the patient still remains a candidate. So those that are asymptomatic or remotely asymptomatic, so they've had their symptoms over 6 months ago, carotid artery stenosis, for these folks, aggressive medical management is still recommended. However, carotid endarterectomy may be considered for some highly select patients with stenosis of 60 to 90%, and if their life expectancy is greater than 5 years. So for what's new here is in women, the benefit of carotid endarterectomy with stenosis of 60 to 90% is really not clear and should only be considered in highly select patients in consultation with your stroke experts. And however, there's several factors that may sway your decision about revascularization. Is if there's progression of the stenosis, if you're seeing covert brain infarcts, if there's embolization, or it depends on the plaque morphology, so the structure and the form of the plaque. This is a new section about symptomatic vertebral artery stenosis, which basically is recommending medical therapy over stenting. And for symptomatic intracranial stenosis, this is not new. You're still, for these folks with 70 to 90%, the DAPT is on for 3 months, followed by monotherapy and then good tight vascular risk factor modification and blood pressure treatment. And for carotid or vertebral artery dissection, what's new? If you suspect dissection for patients with ischemic stroke or TIA that is preceded by head neck trauma or some kind of cervical spine mechanical trigger event, or you've got prominent head or neck pain, you may want to suspect a dissection, and I think we already do that. So for management, there's still uncertainty about the comparison between antiplatelet therapy versus anticoagulation with heparin or warfarin. So either treatment is considered reasonable. Decisions should be based on, individual risk-benefit analysis. And what's new here is that when you're looking at this, you should consider some of those imaging features, the degree of the stenosis, whether there's a pseudo aneurysm, and basically the patient characteristics and estimated bleeding risk. So we're almost done here. So other cardiac issues, I didn't notice really that much, just under the PFO PFO section, and there wasn't really that much there. But since the last update, there have been more trials and more, and there's been a meta-analysis which further supports PFO closure for select patients based on, their strict criteria of age, 18 to 60. They've had to have a diagnosis of stroke as confirmed by imaging as non-lacunar embolic ischemic stroke, and the patients have to be evaluated by a stroke expert. The cardiology interventionalists here at KHC are now starting to do PF closures in the cath lab, and it'd be interesting to hear what your process is like up in Sudbury and elsewhere up north. So the biggest change is that this update has removed TIA. So TIA used to be here, but there's less certainty with TIA compared to ischemic stroke. It used to refer to patients with ischemic stroke or TIA attributed to PFO should be referred for consideration, and now it's just ischemic stroke. So what's new? It's reasonable to recommend against PFO closure if your patient has none of the following. So they have to have an atrial septal aneurysm, or like a large right to left atrial shunt with many microbubbles, and they have to have a large PFO. And under clinical considerations, so for patients requiring long-term anticoagulation, warfarin can reduce recurrent stroke. However, this benefit may be outweighed by the increased risk of major hemorrhage, and the role of DOACs is still unknown. And the last slide, cancer-associated ischemic stroke is a brand new section. Cancer can increase the risk of stroke, particularly among persons with lung cancer or more advanced cancers. Thrombosis is a common complication as a frequent cause of death in cancer patients with a history of stroke. So patients with active malignancy who experience an ischemic stroke or TIA should undergo a standard etiological workup for their stroke, including vascular imaging and cardiac rhythm monitoring. So we should still do that. And stroke mechanisms associated with malignancy may be considered when determining what your investigations are, including non-bacterial endocarditis, hypercoagulopathy, embolism due to venous thrombosis, tumor-related vascular compression, and stroke-related to anti-cancer treatments. And we seem to see a lot of that, and it seems to be with the anti-cancer treatments. In patients with active malignancy and ischemic stroke or TIA in whom a cancer-associated hypercoagulable state may have contributed, anticoagulation could be considered over antiplatelet therapy. And then, if so, low molecular weight heparin is preferred. So under clinical considerations, the management decisions for those patients should be made in collaboration with experts in hematology, oncology, or thrombosis, and should take into account a few things: the type of cancer, risk of bleeding, the extent of the neoplastic disease, the patient's overall prognosis, and their express goals of care. In patients with active malignancy and ischemic stroke or TIA, plus they have a DVT or a PE, in whom the stroke is presumed to be related to this, anticoagulation for secondary prevention should follow the guidelines for the management of DVT and PE in cancer patients. Okay, and here's a link here to Thrombosis Canada, which is an excellent site, which has more information. And here's a summary slide. And that's it for me, Sue. And I went way over my time. I apologize.
No, it's good. There's so much information and it's a bit complicated, especially for me, but there's lots of information. So I'm glad people could stay on and listen. Does anyone have any questions or comments about some of the things that Colleen has been sharing? Maybe you could just stop sharing your screen, Colleen.
Yes, I'm going to. I'm just, I'm having troubles. Stop share. Okay.
So you can unmute, you can write it in the chat. I know some people have been emailing to ask for certain things. So I'm going to do a follow-up emails asking kind of things I wrote down that you might like printed off and laminated and in your clinic. So I'll send an email to everybody and you can let me know if it's something you're interested in. But please go ahead with any questions you might have.
Do you have any interesting things to share in relation to the best practice guidelines, I'd love to hear from you. It's a lot to digest, isn't it?
It's a quiet group. I'm very surprised. Come on, girls and boys.
Yeah, just, we don't have any questions here. Yes, in Sudbury.
Thanks, Kathy.
Thank you.
Mhm. Anybody else? Deanne, Lisa and your gang, Catherine in North Bay. Is a lot of this new to you? Did you know some of it?
Yes, I would be interested if this was new to you. Or I'm sure we're familiar to like nearly all of these changes.
Well,
I won't
people,
speak for Catherine, but yeah, some of it's new to me for sure. And Catherine and I were chatting a little bit via text during the presentation, and we do have some changes to make. So it is a lot to digest, but it was very well done, and we look forward to making the changes.
yeah, thanks. That's Christine from North Bay. Thanks, Christine.
Yes, thank you very much. It's Catherine,
Yeah.
North Bay.
Yeah.
There
Yeah.
are some things, there's definitely some that we've gained from that for sure that we're going to have to implement in our program. So thanks so much.
Feel free to keep typing or talking. I did put up a slide just about what Part B will look like. I wanted to give everybody an opportunity to digest this information, think about what's happening already in their clinics, and then get together to talk about it further. So our Part B would be, what updates are we already doing? How we were able to adopt them. What do we need to put into place soon, and how are we going to move that forward? Maybe what the stroke nurse role is in the clinic, sharing of some resources or tools that you might have, or a certain patient story that would be interesting to share among our group in the Northeast. So I'd like to kind of book a date and a time for that online here, for that opportunity. I don't want you to have to do a lot of prep work for it. Think about it. You could do a slide or two for your clinic that says, kind of your updates that you've done or updates you're concerned about or something. And I will kind of run the roundtable as an opportunity for discussion amongst the 4 sites. So I'd like a suggestion for timing of this. I'd love to do it in February, March if we have to. I just want to get it in before year-end budget of March 31st. I think it might take more like 90 minutes rather than 60. I was thinking over the lunch hour might be best for you, but if you could let me know a day of the week that's best, or a time that's best, you can just type it in the chat, or you can unmute.
It's
For us in North Bay,
Kathy.
Monday,
Oops, sorry, go ahead.
for
ahead,
North
North
Bay, probably Monday, Wednesday, or Friday
At lunch?
are best, because that's when Catherine's in the clinic.
Okay.
Does lunch hour work for you, Catherine?
Lunch
Sorry,
hour is
yes,
good
it
for
does.
us too, eh?
Okay.
Lunch is good.
Okay. And Kathy at HSN?
Yeah, Friday's probably good on
Friday.
the lunch hour. But I mean, if we could maybe wait till things settle down a little bit more, maybe after what? Well, someone else said that too, after February. After February, like maybe even early April.
Well, I'd like to keep it before year end.
Okay, maybe late March.
Yeah, I hear you for sure. I heard that, we've reached the peak and we're on our way down. I hope that's true.
Yeah, me too.
Okay.
I think Sudbury and Kingston were at the peaks earlier on compared to the rest of Canada.
Maybe.
Yeah.
What about the Sioux, Lisa?
Mondays aren't good, but
How's
Fridays
Friday?
are good. Fridays are really good, actually.
Okay.
Friday's my best day for North Bay.
Yeah. Okay. We're going to do Friday. I'm going to send out a date. I'll check in with Nick up in Timmins. and see what I can book after February 21st. I'll try and book for March sometime. Hey, any other comments or questions from anybody?
And maybe do like 11:30 to 1,
Sure.
something around like that time.
Yep.
Are we getting these slides?
Yes,
I really like the slides. It's a brief.
yeah, I sent them out at the beginning of the
Good overview,
presentation.
actually.
Did you get them? I sent them out.
I haven't looked on my email.
Yeah, I sent them out after we started.
Pay
So
attention.
I thought, good for you, Lisa, gold star.
Thanks.
Yeah. And I'm going to send a follow-up email with some ideas of things you might like printed off and laminated for your clinics. And I'd be happy to do that for you and send it out.
Okay, thanks.
Anything else from anyone?
I just wanted to say thanks so much. And if like, I'm really interested in people's development of resources to help you with putting best practices into your practice. And one project that I'm really interested in is how are you doing with anticoagulation adherence? So if you have any tips or ways of going about that, I'd be really interested. If you wanted to share it with Sue and then Sue can forward it on to me, that would be wonderful.
That'd be great. Thanks. We'll wrap up. Thank you, Colleen. I appreciate your time that you took to put this together and spending time with us today. It really meant a lot. It gets us well on our way to doing maybe a bit more work around updates and secondary prevention. And so we really appreciate that you shared it with us today. Thank you very much. And I wish everybody a good day. Please stay healthy and stay well.